Good evening and welcome to COVID-19 Updates from Singapore. This is episode 38 and your final episode. I'm David Allen, your host, along with my co-hosts, Louisa's son and Dale Fisher, welcoming you and appreciating you joining us on this final episode. Hi, Dale. Hi, Louisa. Dale, where are you?
I'm in Geneva, David. It's the center of the universe when it comes to outbreaks.
Weather nice? Tropical?
If you like, 1 degree and brisk wind. Yes, it's a nice change.
Louisa, where are you?
I'm still here in Singapore, sunny Singapore.
Did you get there through the VTL or you just get there on your own?
No, I got lucky. Yeah, I got tickets.
Oh, okay, super. All right. Dale, who will you be introducing us tonight or chatting with tonight?
We had Mike Ryan about a year ago, and I was lucky to pin him down again. So yeah, we've got a really deep dive into how the outbreak's gone at a WHO level from the man at the top.
Looking forward to it. All right. Well, tonight's show, it'll be a little longer than an hour. It'll be an hour 15, hour 30. And the agenda's changed. As Dale mentioned, he'll be introducing and speaking with Dr. Mike Ryan, and then seeking his perspectives on the pandemic. Then we'll shift from the global view, from the WHO's perspective, to a more regional Southeast Asian Singapore perspective with Professors Tan Chorh Chuan and Sophia Archuleta, who are well positioned to comment on how Singapore has responded to the pandemic from a research and development perspective, as well as from an academic clinical perspective. We will be taking questions for a change, and there's been a lot of requests for that. So during the second segment, we certainly ask you to submit your questions to the Q&A tab at the bottom of your Zoom page, and we will try to get to those. And we'll end the show with Louisa, Dale, and myself sharing our views on a state of the pandemic and acknowledging those who have made the show a success, and close with some crowd favorite video and a pandemic song of the month to take us out. So Dale, without further ado, over to you.
Sounds all fairly straightforward, David.
Yeah.
Few moving parts, nothing could go wrong.
Absolutely.
As I mentioned, I caught up with Mike soon after I arrived here a couple of weeks ago, and earlier in the week was able to get an interview with him. He first joined WHO in 1996, actually, so he's been here on and off, I guess, for 25 years. Then he established a unit that responded to emerging and epidemic disease threats. He's a founding father of GOAN, actually, which was established in 2000. But Mike's really a guy from the field. He's led and been involved in many field responses. He's been senior in terms of polio eradication and many EVD, Ebola responses, and obviously as executive director of the World Health Emergencies Programme. He's really been the global face of the pandemic. So, Joe, can you play the video, please? So thanks, Mike, again for being so generous with your time for GOAN and the partners, and for our webinar series. As you know, this is the last in the series, and we couldn't think of anyone better to talk to you at this time than you, of course. And thanks again for hosting us in these hallowed halls, the executive boardroom, where so many
walls could talk.
Famous events have happened, and of course the regular press conferences. But seriously, Mike, WHO is a very humble organisation. It doesn't blow its trumpet well enough, in my view. So can I give you a couple of minutes just to tell me some of the good things, some of the really proud achievements through the pandemic, and in fact, whether it's preparedness or the readiness component or the response. Tell me what you're most proud of that the organisation's done.
I'm not so proud of any specific achievement, Dale. I'm really proud of the people. I'm really proud of the teams at all levels, in the countries, in the regions, and here. The way in which they've really, and it's the same for you, I'm sure, in your role in Singapore and within GOAN. We've seen so many people in public health and in science and in frontline medicine really stand up for their responsibilities. They've worked so hard. They've worked, some of them 7 days a week, 24 hours, right the way through this pandemic, and they've really managed to stand up for science. And I think in that sense, the achievement we've had collectively is that we've stood up for public health, we've stood up for science, we've stood up for frontline medicine, and we've shown our populations what can be achieved when that's done well, and when data is driving policy, not the other way around. And when we strive in public health to deliver on science, to deliver on knowledge, to translate that knowledge into practice and into policy, and translate those policies into something that's implemented, that makes has a meaning in people's lives. So I would say, at different levels of the organisation, we've seen what our teams have done on the ground, and it's fantastic how they've supported governments and NGOs and communities. At HQ level, and it's been tough the last 2 years because I haven't been able to travel. Normally when we have operations in the field, I would be going to places and seeing, feeling what's on the ground. Here in Geneva itself, an amazing bunch of people in the incident management support team who've really come together across so many different pillars of activity. And the achievement, I think, for them has been the ability to process so much data, so much knowledge in real time, and then engage and deliver that knowledge through training platforms, through guidance, through webinars, through social media and others. And that's been the biggest lift I think the organisation has ever had to do as a whole organisation. And to see people from various departments, various divisions come together to deliver on that has been it's been a huge privilege for me to work with all of those, to work for Dr. Tedros and his leadership role, and to be able to deliver on what the world wants from WHO. And again, emphasising that WHO is not the secretariat here in Geneva. It's all of the organisation itself, but it's also the member states of that organisation. The World Health Organization is made up primarily of its member states, and we act in service of those member states, and ultimately we with the government act in service of the citizens and of people. And I think there's been a huge effort to support people in this response. So not so specifically proud of any one achievement. We've had setbacks, we've had difficult days. It's been a pandemic of a virus. It's also been a pandemic of misinformation and blame. I'm sure you've experienced that yourself in Singapore. And at the moment, at one hand, a great triumph for science, and a moment at which science has come under the greatest scrutiny and sometimes abuse than I can remember in my career.
I've seen some of that abuse, experienced a little of it, but I know I've seen some of other high-level people at WHO getting terrible things thrown at them, and even countries turning on WHO. How have you carried yourself, or WHO staff carried themselves through, the discouraging times, the is it all worth it times?
It's a good question, Dale. I think at one level, certainly in the Emergencies Programme, we're trained to deal with adversity and pressure and stress, no more than frontline police services or fire services are. We work in public health. Those who also work in emergency medicine or in emergency public health, we're used to dynamic situations in which there are tensions and stresses and fears. So I think we probably have a level of tolerance to that maybe higher. But it did at times, the rhetoric and just the words and the hurt that was put out there, not just towards us but towards other public health leaders in countries, was really, really hard to bear. In fact, the physical exhaustion and the mental stress of having to react to a virus we didn't know about, trying to understand every day, trying to move resources and goods and supplies around the world while trying to gather data at the same time, while trying to set policies that were rational across a whole globe. All of that was really, really stressful, hugely demanding on everyone in the organisation. And I think we'd have, we bore that like all national and subnational authorities tried to bear that. I think at times what nearly broke us though was the abuse. It was just very hard to take, and we just had to work with each other. And to be honest with you, I've been amazed with the outpouring of support from our scientific public health colleagues around the world. I can't tell you the number of notes, messages, WhatsApp, signal messages I've got from friends, colleagues, people I never even knew, just saying, go for it, don't worry about the naysayers, do your job, we support you. So I think, really, really tough, but those messages simple little things. I think people just sending cards, people just sending all of that kind of stuff. I remember, it's an interesting anecdote, but I remember Maria's son. It was really, really tough time in the pandemic, and we were under an awful lot of pressure and really been assailed and beaten down a bit. And I remember coming in one morning and Maria said, my son Cole did this for you. And there was a picture, hand-drawn picture, and there was a rainbow on it with the sun coming out, and underneath it said, good job. And I've had that up in my office, and now I'm deeply stressed because we moved office to a new office and I can't find it. Right? So, but it was a simple act of a young boy just to just empathise and say, don't worry, good job.
It's easy to forget those, isn't it? It's you focus on one or two nasty messages or blogs or social media things, but you're right, there's a lot of people that, and again, as you say, people you don't even know that say thanks for all you're doing, and you just...
And don't get me wrong, we should be held to account. We all serve people, whatever level, your level, Dale, the government in Singapore, ourselves here, all over the world, and we have an accountability to the people we serve. So it doesn't mean life for us should be perfect and everyone should be just bowing down saying you're wonderful. No, not at all. We bear an accountability because we interfere in people's lives. We make decisions that affect people's lives, be it their freedoms, be it whether or not they have to have a vaccine or not. We, in the work we do our best to serve those people, but at the same time we're accountable for the quality of that. And public health and our work we do in science is not about best effort, it's about excellence, and we should always be trying to achieve excellence. And when we fall short of that mark, we deserve criticism for that. But what we deserve is constructive criticism. What we deserve is identifying the problem, or what went wrong, or where did we not perform at the acceptable level, or at that level of excellence we expect from ourselves, and how can we improve. That's a constructive way to engage. But what's happened throughout this pandemic, and it doesn't matter what level you're at, is that kind of constructive engagement to improve things seems to have become less important than the talking heads, the social media, just attacking people for who they are, or for where they are, or for what they represent to them. And that's very difficult to understand because it's a kind of passive engagement. It's not really engaging with a person that you wish to criticize or you wish to understand, well, why has this gone wrong or why has that gone wrong? Can you tell me? Can you explain from your perspective? Can we discuss this? It's not that way of engaging. It's much more fire and forget. People can throw stones and then disappear into the social media. That's not functional.
I still get criticised for recommending only wearing masks when you're sick back in February 2020, which was the advice then. That was the extent of our knowledge, but still I hear this is the guy that told us not to wear masks. And yeah. So let's go to the response. We all felt public health systems could do it with good contact tracing and good isolation processes and testing and all the conventional things, but border controls came in very quickly. Lockdowns were very fast in various forms, and all the social restrictions. I didn't really see that in the outbreak response or the pandemic response playbook. Did you see this as being the cornerstone of the response?
Not really in terms of the kinds of global lockdowns, and when you use that word is it's a basket of things. Did I expect the next pandemic of respiratory virus to require public health and social measures? Yes. Did I expect, as this pandemic evolved and got to so many countries, that it could be contained purely with contact tracing, containment and isolation? Probably not, because there really wasn't the will to do it. I mean, places like Singapore had huge success with that approach, but that requires a particular kind of readiness and preparedness, which you had done in Singapore, and a particular attitude from communities in terms of trusting the services, and a particular I suppose, ambition or steadfastness of governance to sustain and implement a series of measures over a period of time, and to do that in a layered way. I think what we ended up, and I didn't expect this, we ended up in a do nothing or total lockdown, flip-flop world, and that never works, and has never worked for anything really. But we ended up in this bifurcated world. Lockdown, no lockdown, masks, no masks, believe in vaccine, don't believe in vaccine. The number of dichotomies in this, and it often ended up coming down to your politics or to which side of a political spectrum. The oversimplification of the issues in people's mind, and this absolutism was I think, really, I didn't expect that. I think countries were not ready for layered public health measures, where you can scale up and scale down the measures you do to modulate the impact of a disease. Mm. And unless you practice that, that's a bit like playing a musical instrument, right?
Yeah.
Unless you've practiced that, you can't move up and down through the notes and through the chords unless you've been doing it. You can look at it on paper and you can say, yeah, that's that music, and I can hum it away for you here. But can I take up the instrument and play that in a real-time situation in front of an audience with all of that pressure and stress? That takes practice. And I think what we had was a lot of pandemic preparedness on paper, a lot of rhetoric around what pandemic preparedness was, without the really worked and tested systems that would be able to scale up and do this kind of very complex dance, very complex piece, and do that in an assured way. Some countries did that better than others, and particularly in Asia, where there was a lot more pre-pandemic planning, real planning, with exercises, with working through scenarios and saying, what would happen if we had 3 cases of this or 5 cases of that? What would happen? And then looking at being able to layer the level of restriction on people's movements or whatever according to the epidemiology of the virus. And that requires being able to detect what's going on and measure what's happening in real time and modulate the level of intervention accordingly. I think a lot of countries, again, countries that got ahead of the curve with contact tracing with the ancestral strain. It's questionable now with the Delta strain, with its transmissibility, to what extent case finding and contact tracing can be effective unless you're at relatively low numbers. But certainly in the beginning with the ancestral strain, many countries demonstrated that it was possible to keep this virus under extreme control. But it required fairly extreme surveillance, and it required a very strict adherence to case finding, to contact tracing, to quarantining contacts. And I think that probably became the biggest issue, Dale, I don't know in Singapore. The ability and willingness of identified contacts to self-quarantine and be in supported quarantine was a major issue. And just were so many countries that just could not even attempt that, never mind sustain it. For different reasons, political reasons, for financial reasons, for all kinds of reasons. So I think what I was surprised with was that lack of agility and dynamism. I think I've said this to you before. Pandemic preparedness was much more seen as a static thing. You measured how many beds, how many hospitals, how many labs.
And in fact, the indices got it quite wrong, didn't they?
Yeah, and you tick all these boxes. And that's like measuring how someone's going to do on the sports field by just measuring how much they can bench lift and how fast they can run on a treadmill. And you can measure those things and you can say, wow, you're very strong. Ooh, you're very fast. Ooh, and you're very fit. But that doesn't measure how you're going to do in a game when someone's trying to take your head off and the crowd are screaming at you and everything's happening in real time. The only way you can adapt to that environment, that performance environment, is to put yourself in that environment. You'd either do it in real time, in a real situation, by using epidemics and smaller outbreaks to test yourself, or you use exercises to do that. You put yourself artificially in that situation. And what you're doing then is testing the dynamic capacity of your system, not its pure strength, but its agility, flexibility, its scalability. And what was missing in this pandemic were those three things: speed, scalability, and then agility. Those three things. Countries that were able to react and scale up quickly, and then were able to adjust that scale up and make it more precise, adapt their response to what they were seeing in the data. I think in general those countries have done reasonably well, you know.
Yeah, but underlying those three illities is leadership and community engagement.
Absolutely.
And I think the countries that had the right leadership, whether it's the leader or the leadership structure, which adapted to the outbreak, and also had the trust of the people or engaged the people in an appropriate way, they did the best. So how can we do that better next pandemic, the leadership and the community engagement? It's obviously there's a cultural component, there's a political component, and Western democracies, you could argue, struggled more. So is that even fixable? Or is it the way it is?
Maybe it's a bit of the way it is. I think long before this pandemic started, I did a lot of lectures and stuff for students and training stuff, and I used to say to people, there are three most important things in epidemic response. What are the three most important things? Students would try, and I'd say, no. I said, the three most important things in epidemic response are governance, and governance. Right?
Yeah.
And I say that not in governance in the sense of government, but governance in terms of the ability of the system, whatever that organization is. And it's not about democracy versus something else. This is about how is the state governed in a way that adapts itself to a successful response to an epidemic and does it quickly and dynamically. I think you're right. A lot of that's based on how accountable a government feels for the welfare of its own population. It also depends on how it can make decisions. I mean, what are the legislation? What's the architecture of having that power during a pandemic, and how is it applied? And how dynamic a government is and willing to take on board science and data. And what that link between governance and science was key. It wasn't just lack of governance or good governance. It was having in place good governance that was listening to science and then willing to apply policies that were based on scientific principles, while understanding that pure science doesn't turn straight into policy, because you have to consider other things. There are trade-offs, socially, economically. But none of that works if you don't have the trust of the community and the engagement of the community. And I think there are still societies in which science and medicine is trusted, and even where governments are trusted, but I think trust in both those institutions has eroded over the years. And in some cases, that's a positive thing, in the sense that we do need a healthy debate, and citizens need to have a healthy debate with medicine, with science, and with government. Gone are the days when governments and medicine in particular, or public health, can just shove things down people's throats. Do it because it's good for you. That's gone. The old day when the doctor could tell you what to do and you went and did it.
Trust your doctor.
Trust your doctor, right? That's great, and we want to build that trust, but that's not a given anymore. That's not a primary given. That's an earned relationship.
Because Dr. Google's there as well.
Because Dr. Google's there as well. And so I don't think we should see this as a negative thing per se. I think what we need to see it's a new demand. It's a new relationship. It's a new way of building relationships with people and with communities. And we in the public health and in the science and medicine professions need to understand that the rules of the game have changed. No longer is everything that comes out of our mouths almost God-given. It's not. People need to be communicated with and engaged. You use the word, I know you use it very consistently, engagement, right? Because engagement isn't just taking out a megaphone and shouting at people, right? That's shouting. And I think that idea of how our communities engaged, and then within communities to recognize that community is not an amorphous mass. It's not, within communities are sub-communities. And they may be ethnic, they may be they may have a sexual orientation, and that, in many ways, societies have fragmented a little bit into those sub-communities. And therefore you can communicate well with one community and you're completely missing it with another, because people are no longer bound by geographic communities, and people don't identify only with their geographic community. It's not the village or the town, and say, okay, if we can convince town X, then everyone in the town will move with us. Well, the person in town X is also of a certain gender, and they're online with the community. They're also of a certain religion, and they're online with the community. So the influences upon people are now multi-sourced. And therefore we need to be much better, like we are trying to do with our EpiWin network and WHO, is engaging the world of work, engaging religious and faith communities, engaging all kinds of different communities that people feel part of. So when we say the word community, we don't just mean the people in the houses around you in the town or a village. We mean the communities that you feel part of, and the communities that influence your behavior or your beliefs as a person. And we're all in those. We're all participating. And we in public health need to, I really have not taken that issue seriously enough. But we shouldn't, there's people are confused out there around certain public health and social measures around vaccines at the moment. A good deal of people are hesitant, for example, for vaccines because they've just been overloaded with information. They don't know what's good and what's bad. They're not against vaccination, they're just confused by the information. They're not quite sure. They've been told this, they've been told that. So there's a kind of a tsunami, an information overload. And then there's a proportion of people who are being influenced by misinformation. And we need to take these two things apart. Because what we do about information overload is maybe learn ourselves how to present information to people in a better way, how to communicate and engage people with better translated information that meets their needs and answers their questions, rather than just a download from our system to communities, which often overwhelms people. But then, underlying that, or apart from that, are these really, and the thing that concerns me the most is the misinformation, the weaponization of information and messaging for such a negative impact on people's lives right now. And to see, for example, in Europe, as we have this conversation, to see older persons and vulnerable people dying in European countries, in countries that have access to vaccine, because they've been misinformed around the vaccine's benefits and dangers. That's horrific.
Final question, and you don't have a day to answer. It's about where we're going. I know you've got the World Health Assembly special sitting, I think, next week, and obviously the global health security sort of landscape is going to change a lot. So where do you hope it's going? Where do you think it's going? What will we look like going into the next pandemic? If it happened in 5 years' time, what would the players look like? What would WHO look like?
Well, we'll see. We're of our member states, so our member states will decide what WHO looks like in 5 years. 194 of them. I hope that this pandemic has further cemented the central importance of WHO. More importantly, the central importance of public health and primary health care and of universal health coverage. That health is no longer a cost. Health is a human right. Health is a bulwark against the pandemics and health systems and public health systems. That investing in those is not only a human rights issue, but now it's a human security issue, and that we'll see those investments come. I think we can no longer separate the issues of social justice, health justice and climate justice. I think the drivers on the planet right now, so much of the death and destruction in this pandemic has been mediated by decades of mismanagement of underlying conditions, of people's lack of access to healthcare. The impact of this pandemic was not just by the virus. It's because of underlying injustices in the way we deliver health and health protection to people. And then obviously climate and climate shift is driving those epidemic risks and pandemic risks into the future. Not only through the shift in the climate, but the way it's changing agricultural practice, the way that's changing migration patterns, and that lack of governance you're talking about, which has been so destructive in the response to this pandemic, is also driving instability across many other areas. We're in a very unstable period in terms of government fragility around the world and conflict. Vulnerability is increasing, as I said, because of social, climate and health justice issues. So that's the downside. The upside is, I think there's a growing realization that we're stewards of this planet and that we need to get to grips with these issues. And there's a younger generation who just don't want that to be their future. They just don't want that to be their future, and they're much more active. And I sometimes when you're at the point, near to the point of closest to defeat is when you can snatch victory from the jaws of that defeat. And I think we're at that point now. And that's, I think, what the World Health Assembly is about at the end of the month. It's about a reset. It's about saying it won't be a solution in itself at the end of the month. You get all of the member states of WHO getting together in an extraordinary meeting of the World Health Assembly. And it's the World Health Assembly, right? Only for the second time in 70 years has it convened on an extraordinary basis. This is second time.
What was the first one?
I think maybe the first one was there was an extraordinary meeting about COVID, right? And it's for me. What the member states will do, and this will be a member state-led process, not led by us in the Secretariat. They're coming together to look at the merits of a treaty or a convention, a pact, whatever you want to call it, the language, right, that will commit countries going forward to the essential investments we need in pandemic preparedness and response. And I think it's really more a constitutional document that's going to lay out what those commitments are going to need to be if we're going to do better in the next pandemic. And that's not just going to be about having better surveillance systems, yes, but we need better sharing of biologic material, we need better sharing of data, we need a better, stronger, more resilient, better protected health workforce, we need a better medical supply chain that can deliver PPE to everybody when they need it, we need much more streamlined R&D that will lead to contracts that allow everyone to get access to vaccine at the beginning and not the terrible inequity we've seen right now. We need better financing systems so we can put money into preparedness, not only into response. We keep putting money into response and we fail to invest in preparedness. So we need to change the way we're financing health security. So when you think about those things, the current political generation have a decision to make, the leaders globally, from nations to global. Either this generation of political leaders will be remembered as a generation who really screwed up a response to the pandemic and then did nothing to fix the inherent underlying issues that drove those failures, or they'll be remembered as a generation of political leaders who fought bravely against the pandemic and then were prepared to look at what was needed to stop the next one or make sure the next one didn't do the damage it did. And I think this is, in that sense, a historical moment. The treaty or the convention won't be agreed at the end of the month, it won't be finalized, but it will trigger the process by which it's done. So if this process is triggered, then we have time to negotiate and get this thing right. If it's not triggered, then we wait another year, 2 years, 3 years before we even start talking about this. And I don't think we have that time. I really, Tail, you're down there in Southeast Asia, you know the biomic pressures, right? Singapore has been aware of these pressures for years and has prepared, and part, I would suggest, of the success in Singapore has been that almost fear of these diseases that has driven committed government action over a decade, since the last SARS, to actually put in place the things, and it doesn't change the world. It's not massive investment. It's targeted investment in preparedness pays off. And I think it's paid off in places like Singapore. What we need is every country in the world doing that, and every country in the world agreeing to collaborate around these more international behaviours, international systems that we need going forward. So yeah, it's a huge moment at the end of the month. We're hoping to have Gordon and other players speak at it because of the important nature of this discussion. But again, it's up to the member states. It's not us. We in the Secretariat don't have a vote, and we don't have a say. It's up to our member states to decide what they want to do next.
Thanks, Mike. Executive Director of the World Health Organization's Emergencies Programme during the most defining pandemic of all time. I know you're one of those 24/7 guys. Mike, thanks for all you've done in the pandemic.
Thank you, Dale. Thanks to you.
Dale, very nice interview, very interesting, very informative. He's quite laudatory about Singapore. No country's perfect. What's your perspective on that, my friend?
That morning, actually, I'd given a presentation to WHO, which really talked about all the preparedness and readiness effects I had, that Singapore's been going through. So it was high in his mind, and I gave plenty of examples, including the establishment of NCID and all the simulations that we do every year, and the development of the negative pressure rooms and human resource, recruiting people like you, David, and me, everything Singapore's done. So there was a bit of history there. He just had a lecture on it from me for half an hour.
Well done. Well done. All right. Well, we're going to build on that momentum that you nicely generated and transition from the global pandemic preparedness perspective and the unique perspective of WHO to one more regional, more local. And it's our great pleasure. Louisa and I are going to speak with Professor Tan Chorh Chuan, who is former president, National University of Singapore, former director of Medical Services at Ministry of Health, and since January 2018, he's been the chief health scientist at Ministry of Health, and now also the executive director of the Ministry of Health's Office for Healthcare Transformation. Additionally, we're speaking with Associate Professor Sophia Archuleta, Head of Division of Infectious Diseases at the National University Hospital of Singapore, and Director of National HIV Program, National Center for Infectious Disease, and a member of the National COVID-19 Therapeutics Working Group. Thank you both for joining us this evening, taking time from your busy schedule. I'm going to jump in, and Louisa and I are going to pepper you a little bit, but please, the questions are open-ended and meant to be expanded on. So, Chorh Chuan, if I can begin with you and give us a little perspective on your assessment of Singapore's R&D pandemic preparedness pre-pandemic and how we've done during this pandemic from an R&D perspective, or whatever perspective you'd like.
Well, thanks, David and Dale. So nice to be able to join you today, and Louisa as well. I think we have invested very heavily in the health and biomedical sciences over the last 2 decades, and we have therefore built up quite an extensive range of research capabilities. And in this pandemic, we've seen how these capabilities have been able to come together in service of a national need at a time of crisis. Overall, I would say our researchers have done well during the COVID-19 pandemic. And I'd like to highlight 3 reasons why I think this has been the case. The first has been the incredible amount of collaboration across groups, institutions, such a high level of collaboration, and a lot of preparedness as well. So, for example, there have been protocols that have been worked on a few years before this pandemic on what kind of samples, what kind of data to collect if a pandemic occurs, who will hold it, how will it be released, pre-agreements have been signed, and protocols have been put in place. And this has allowed a very rapid accumulation of data and materials, and that's really driven a lot of the research coming out of Singapore. So a high degree of collaboration that has dated back to the days before the pandemic. The second is I've been very impressed with how the different researchers have worked together, And there are many indicators of how this has been of impact. But I'll just point to the fact that since the beginning of this pandemic to the end of June, Singapore researchers have published more than 1,800 journal articles, which is, if you think about it, more than 100 articles a month, which is quite extraordinary. And several of them in very, very good journals. And I think this has been enabled by the fact that we've been able to collect data and materials and share them quite extensively across the research ecosystem. And finally, I would say a really striking feature of this pandemic has been the very close linkage between the public health agencies, the ministries, and the research community, so that the research that we're doing is very well aligned and responsive to the public health priorities. So in the early days, we started off with a lot of epidemiology, virology. Then a lot of the focus was on diagnostics, and we were able to bring diagnostics through from discovery to productization and manufacturing in ultra fast time. Then we ran a number of, or we participated in a number of multi-center trials, for example, of remdesivir, of some of the monoclonals. We then switched to doing environmental transmission types of research when the whole aerosol issue was up in the air. And then more recently, a lot of focus was on the nature of immunity after infection and after vaccination. And now we're doing research on immunity after boosting. So I would say that the high degree of alignment between what the researchers were pursuing and the public health agenda was a very important feature of this pandemic.
All right, great. Thank you. I appreciate the expansive answer. That helps. Let me kind of transition the same thought to Sophia and ask you what steps were taken early in 2020 when our first cases were coming in, or before that, that allowed the hospitals to respond in a meaningful fashion, and what did they learn subsequently? Were we prepared?
Were we prepared? Yes, David. Thanks for that question. I'd say a lot of it does have to do with alignment, as Chorh Chuan said. So being aligned with the ministry task force at the government level, all the way down to regional health system level, to hospital leadership, and ultimately to infectious diseases divisions, such as that at National University Hospital, which is where I am. I'd say establishing strategy early on was incredibly important. So having a focus in terms of what are our goals for transmission and safety. We here at NUH aligned around what we call the 4 zeros. So aiming for zero transmission from patient to patient, staff to patient, patient to staff, and staff to staff, aligned at the time with the whole country approach of going after cases with strong contact tracing and aiming for zero nosocomial transmission. That type of strategy served us well for almost an entire 18 months into the pandemic. So it wasn't until July of this year that we broke our first zero over here. And then other aspects of strategy were more around clinical care. So issues around balancing COVID and non-COVID care of patients, especially at tertiary and quaternary care hospitals such as ours, balancing our clinical mission with our academic mission. So setting that strategy very early, I think, was important to what ultimately I believe we were successful in doing. Governance, another aspect that came up earlier in terms of how important it is in our pandemic response, very important at the hospital level as well, having the structure in place that incorporates clinicians, nursing, operations folks, leaders across all departments and areas of the hospital must come together to execute that strategy early on, and then ultimately translating it into the millions, I would say, workflows and communications channels that had to be developed and tailored in order to communicate the strategy. and the workflows to everyone in the hospital. We also talked about trust earlier, Dale and Dr. Ryan. Again, I think it plays very strongly in the hospital level and determines how successful we are. As ID physicians, we're called upon for expertise, but actually we're not really experts, right? At the beginning, we're theoretical experts, perhaps in epidemics and outbreaks in infectious diseases, but it's a novel virus. And somehow we still have to maintain trust in our expertise and our colleagues to have confidence in us. And I'd say most importantly, we did that by being humble about where we were in terms of what we knew in the pandemic, certainly not overpromising things, and always doing things hand in hand with colleagues. So would never presume to tell, a surgeon how to operate or my head of the emergency department how to run her ED, but together working through workflows and tailoring them to the environment has served us throughout, and I feel will continue to serve us, whatever comes next with COVID or after.
Thanks. Chorh Chuan, this isn't going to be the last pandemic. And certainly, despite our best laid plans, we were surprised. In what way were we surprised? And what can we do to mitigate that going forward?
Well, I think we were surprised in some ways, but we also had some advance notice in this case because we could see what was happening in Wuhan in the early days. And I remember when I first read about it, I was quite comforted that the expert opinion was that there was no sustained human-to-human transmission. So I said, phew, good for us. Then, of course, the news came out that there was human-to-human transmission as soon as a raging epidemic. So we were surprised, but we had some time. And I think what stood us in good stead was all the preparation we had made, that we had learned from SARS, and we were able to stand up all those different measures almost immediately, and were able really to contain the first wave quite efficiently. But I think what we have learned, of course, in the course of this pandemic is that the SARS paradigm takes us maybe half the way. But now we have to shift to a paradigm that is more SARS plus flu plus a bit more. Because we have never really had the situation where we had sustained community transmission, where we had to do social distancing, mitigation, the sort of things that are quite common in the flu armamentarium. Many people have not really read very much about flattening the curve. And so we had to learn a lot of those things. And then along the way, of course, we learned that due to the prolonged nature of this epidemic, we also had to deal with the very extensive social issues, the support issues, the healthcare capacity issues, and so on. So I would say we had some warning for this one. We were prepared, but it also showed that our preparation was incomplete. And for the next one, we'd have to now bring on the lessons that we've learned with this pandemic and prepare a more comprehensive response to a much more contagious agent that had a predominant community mode of transmission, and also factor on the possibility that the next virus could be even more virulent than the current one.
So leads me to ask a couple of questions. Number one is, can we afford to do that? Can we afford that investment, or can we afford not to make that investment? Because we're not talking about small sums of money, and we're not talking about 5 years. We're talking a long time.
Well, I think if you look at the amount of money we spend every day in Singapore and around the world just containing this pandemic, I think it will pay for itself, even if we invested in doing all the things that we've done. And of course, I think the trick is that in between pandemics, we have to sustain the effort, and we have to find ways in which we can keep the expertise warm and to be able to mount responses should the need arise. So answer to your question, David, is we can't afford not to do this.
Yeah. And Singapore is it's rich in its resources and its people, but it's poor in material supplies. And I think the pandemic, especially the early part of the first year, really, I don't know if it shocked everybody, but it certainly caught a lot of people by surprise that basic materials for research and development and a variety of other manufacturing, we were vulnerable. How do we mitigate that? Whether it's food, whether it's basic materials, whether it's,
Well, I think one of the interesting aspects of this is that actually our stockpiles have been quite comprehensive, and therefore, we had to scramble like everybody else. But in terms of protective equipment, drugs, diagnostics, etc., there wasn't really long periods of time where we were unable to provide the supplies that were needed. But we required a lot of innovation. So at one stage when RNA extraction reagents were in very short supply, some of our researchers from DSO and elsewhere developed diagnostic kits that did not require RNA extraction. When there were fears that we wouldn't have the universal transport media for swabs, we actually developed PBS or much simpler transport media that could do the same job and so on. So we say that we can build up resilience through judicious stockpiling, plus also some degree of innovation as the need arises, because there is really no way in which we can make sure we be self-sufficient for all aspects of the things that we will need. In fact, we can't even predict in some cases where the real bottlenecks will come out until the supply constriction occurs.
Thanks. Sophia, you serve on the National COVID-19 Therapeutics Working Group. It gives opinions regarding treatment guidelines. Why is it necessary to have national guidelines when every professional society known to man has spewed out their own guidelines for how to utilize drugs? And how challenging is it to keep national guidelines up to date when information is evolving almost daily? And is there a way to make this a living document?
Yeah, let me start with the first part, I suppose. Why is there a need? Therapeutic decisions have to be made in the context of local practice and the local healthcare system constraints. Quite a bit of for example, the early literature on COVID came out of healthcare systems that were, for example, overwhelmed. And as we know, outcomes with COVID largely depend on, say, critical care and other resources, and whether or not that healthcare system is overwhelmed. Also, the way we practice in Singapore was very different. So until very recently, we admitted even to hospitals, even well people with COVID. So when you were looking at, for example, clinical trials that were discussing hospitalized patients with COVID, they were talking about a very different population than what our hospitalized population consisted of at the time. Also, as Chorh Chuan alluded to, we have stockpiles of therapeutics, and those stockpiles can vary across place and can vary across time. So what we are likely to use when, thankfully, we do have therapeutics, but it can vary, and it's something that we need to consider. Last but not least, I'd say, even though I think, as you all know, I believe strongly in clinician judgment and discretion and individualized decision-making about patients, it is important for colleagues to practice somewhat consistently, especially in the early days of the pandemic where there was a scarcity of real evidence. If we don't, it can be frustrating, and it can be demoralizing, and it can be difficult. We talked, as I said earlier, having the trust and confidence of our colleagues is really important. And if they see us practicing quite variably, that can be jeopardized. So it's really about striking a balance among all those factors. In terms of how challenging it is, I'd say vary. The amount of information that you have to sift through, both good data and bad data. The information tsunami, of course, has been real with COVID and retracted studies, et cetera, et cetera. But I think we've done our best, and again, just tried to contextualize the evidence and incorporate both what has been found internationally, also with local data and the local population. what was the last thing you asked me? Oh, about a living document.
Yeah.
Ideally, yes. We're meeting again tomorrow to try to keep as up to date as possible. So we do put out the recommendation as quickly as we can, the recommendations. But I guess we have a ways to go in terms of making it real time.
Let me follow on a question to you, Sophia.
Yeah.
You're the head of an academic division of infectious disease, National University Hospital. What's the prioritization considering when the healthcare systems are stressed? You've got issues of manpower, you've got issues of patient care, you've got training issues, you've got promotion issues. How in the world can you keep all of those balls up in the air?
The priority has been the people in the virtual background behind me, the team. Without the team, I feel nothing would have been possible. And that's not to say that we don't put patients first, but that we felt throughout that if we don't take care of ourselves and do it as a group, then we wouldn't be able to effectively take care of patients. So that's been incredibly important, and I'm proud of how we've done in that regard. In terms of balancing COVID care with non-COVID care has been, I think, our other big priority, again, as an academic health center. Sometimes I felt like my priority and the team's priority was to, in a way, create, see if this makes sense, to create, so all the workflows, almost in my mind, created a pipeline or a road system through which patients could flow to the right place in the hospital. So whether that be in isolation and cared for by the infectious disease or the critical care teams due to COVID, or they went to, our hematology oncology colleagues to receive that definitive care that they required for their non-COVID issue. And to do that in a way that can be dynamically changed throughout the pandemic. So where we had more or less COVID around, or where we had more or less non-COVID type pressures around. That has been a challenge for sure, but it has had its rewards. And our not being able to fulfill our academic mission has been another really big priority. And I'd say we've had tensions throughout when the clinical pressures are so high and the demands towards the rest of the hospital, then how do we take care of our research priorities? Again, as Chorh Chuan alluded to, clearly that's incredibly important and should be protected and looked after, because we would all benefit from whatever we're able, the clinical trials that we set up and the data and the evidence that we collect to help the public and to help ourselves ultimately. And then the academic mission, when else are infectious diseases trainees going to get this much learning? But at the same time, we're also learning from scratch. So the people who are supposed to teach them are also the ones that are learning from scratch. So it's been an interesting journey. The pandemic academy has been tough. It's been a tough academy, but people are lining up to join infectious diseases. So that's got to be a good sign.
Well, we appreciate your leadership. I speak personally. Thank you.
Thank you.
Chorh Chuan, in your view, what's the greatest threat to Singapore? Finite hospital capacity, healthcare manpower shortages, dependence on outside medical supplies, aging vulnerable population, health science literacy, misinformation, et cetera, et cetera, et cetera?
Well, I think talking today, of course, we have a very high degree of vaccine-induced immunity. And with our boosters now exceeding 25% of the population, I think we are in a much better spot. So I would say that, yes, we do worry about older people and vaccinated people getting infected, but on the whole, that has receded as a direct threat at the present time. So I think the main issue now that we are dealing with really is protecting the healthcare capacity, because as Sophia said, we have to keep the healthcare system intact, not just for COVID, because there are other diseases that are as important, that are also life-threatening, and we have to keep our overall mortality as low as we can be, not just from COVID, but from other sources of mortality. And that requires us to be able to run our health system as close to normal as we can. And that requires us, therefore, to put in place measures that dampen some of the transmissibility while allowing a paced opening up of society, even as we continue our boosting program, which we expect will then allow us to do even more. And even as we open up our economy, our society, viral transmission will go up, but the impact will be much, much attenuated. And therefore, we will have a combination of vaccine-induced booster-maintained immunity plus natural infection that leads to mild disease. And I think that would lead to a much more robust and more durable immunity that will allow us then to open up even further in the future.
Thank you very much. Very, very reassuring.
May I interrupt?
Yes, Louisa,
So
please.
I have a follow-up question, actually a couple of follow-up questions. The first, which I would direct to Prof. Tan. So in relation to what you mentioned, how long do you expect the aftermath of COVID to last? And also we're hearing a lot of reports in other countries where their healthcare systems have clearly collapsed quite early on, and they have a terrible, almost second pandemic from non-communicable diseases being ignored and piling up. So how much do you think that Singapore has been affected by that? And is it to a similar extent, is it to a much less extent? And how can we deal with that?
Well, I think I'm always very worried to make predictions about COVID because the likelihood of being wrong are very high. I would say that Singapore had taken a slightly different path because we started out with a SARS mentality, a near elimination approach. Therefore, we did not suffer the same degree of natural infection in 2020 and much of 2021. Then, of course, like everyone else, we were very lucky that vaccines were available and we were able to achieve a fairly high rate of vaccination, 80% before we started to open. And so we, then of course, as you know, we had a spike, a very substantial spike in transmission, but the amount of serious illness was thankfully quite limited. So we did it a little bit differently from many other countries, which experienced large waves of natural infection, then vaccinated during those waves, and then started to reopen, and then found themselves now still with a future, current waves of further infection. I suspect that what might happen is that as more of the world gets vaccinated, as children get vaccinated too, limiting the proportion and the numbers of COVID-naive people without immunity, then we will find that the amount of transmission and the more severe illness will fall to a level which will become much more acceptable to a society at large, and that would allow us then to continue. Yeah. Of course, I mean, as everybody realizes, there are many uncertainties along the way. In particular, how long the immunity conferred by boosting would last, and whether new variants may come along which might escape from the current vaccine protection. So there are these uncertainties still lurking over the horizon, but I think as far as we can see, if we can continue to build up the robust population immunity, that would probably be our best solution to move to a new type of equilibrium with the virus.
Thank you, Prof. Tan. And I think that everyone, in Singapore, all over the world, is very ready to finally, accept a new normal, going back to as normal as we can. However, how much do you think the Singapore public is really prepared or has already accepted as COVID-19 as a self-manageable disease, as a non-scary or non-serious disease for the majority? And if not, do you think there are pockets of the population whereby, messaging may be needed to be improved, and how do we do that?
That's a good question. I think there's been a transitioning that has been occurring when we first started, and Sophia can comment on this, started home management I think there was nervousness on the part of patients as well as their relatives, because up to then we had managed patients largely in hospitals. And so there was a period of adjustment required, I think, in terms of the medical assessments in hospitals, in terms of the acceptability by the public, in terms of the systems that would support people at home through telemedicine, home support, and so on. I think that we have made that transition now largely because home recovery now is the dominant mode of management, and the initial teething issues that were faced have been significantly reduced, and I think it on the whole has become much more accepted both by patients and their caregivers. But I think Sophia could give you a sort of a front of.
Yeah, thanks, Chorh Chuan. I'd agree. I mean, I'd say it is a work in progress, but understandably so. It's a pretty significant transition for the healthcare system to make, let alone the public to make. In terms of home recovery, as mentioned, also in terms of testing. So we've moved away, as folks in Singapore would know, from predominantly PCR testing or even any testing at all, right, to now seeing to the rapid adoption of at-home kits with antigen rapid testing. They're widely available in Singapore. We use them across all settings, at work, outside the healthcare system, and so on. And the other difficulty, I think, in the transition is some of this mixed messaging. So, for example, is it time for us to stop our safe entry check-ins, where we declare every place that we visited using our electronic means, QR codes, and apps? I think they give, they still give the impression that we can contact trace when there's such disease burden around, or even that we want to contact trace when we've, pretty much moved away from that in our quest to going endemic. And I think focusing on, just households, for example, and trusting for the safe management measures that exist horizontally outside households might be time to just rely on that going forward. Otherwise, I think it can get a bit confusing to the public. I'm also ready to drop my mask outdoors. That can also, I think, be tricky in Singapore because you don't know that if you're indoors and outdoors with our tropical architecture, but it's probably safe when you're in the park or walking on the sidewalk and in a non-crowded outdoor setting. I think it's time. It's really time. I would really like to take a stroll without my mask on and just stay 1 meter apart from everybody else.
I think I'll feel naked. I'm not sure.
So I think we're really, really in a period of transition now. But I can't help but wonder, I mean, being an ID physician in the hospital myself, just because of the community numbers that we're seeing now, and even though we have much less of that, the proportion of serious disease is much, much less now with the vaccines. We still see the highest numbers that we have seen, and that is invariably causing some stress to doctors who are still managing on the front lines, and a lot of our primary care friends as well. So in this, do you think that we are still seeing kind of the worst of the pandemic as healthcare workers, as frontline staff? And when we see the rest of the country starting to open up, do you think we'd feel left out? And I also want to ask, how real do you think burnout is among healthcare workers, especially the ID teams?
I do hope to join the rest of the country in opening up, in terms of the opening up soon. But actually, there's a small part of me that craves the opposite. I want to go on lockdown. I think ID physicians didn't experience it the first time around. It'd be kind of nice to be by myself and out of contact for a while. And I guess that ties in with what you asked in terms of burnout. Let me start, I guess, by saying that I feel we've been very fortunate compared to colleagues across the world. We didn't quite face the negative public sentiment or even those, the personal and physical attacks that public health and infectious disease practitioners faced elsewhere. To my knowledge, no ID physician in Singapore has left their post. In fact, we have more young doctors who want to enter the profession than ever before, and that's pretty amazing. Our pipeline of applicants to the training programs is brimming with these just excellent people. And as one of our senior residents here mentioned about this phenomenon, they're just calling they're COVID converts because they're attracted to the field from the extra exposure they got due to COVID. And I think because of that sense of contribution that we all feel. Now that's fantastic. However, it has its drawbacks. So even though we haven't burned out, I do think we are suffering a pretty pervasive case of brownouts. And we are, and that basically describes people who, unlike those who burn out, brown out, a person would continue to perform fine, be working all those long hours, delivering the outcomes that they're supposed to, saying the right things at meetings, but ultimately such a prolonged high-level functioning can have long-term consequences. So I do think we've had some physical deterioration in terms of white hairs, no exercise for several months, self-care has been neglected, relationships with families and friends have suffered, and our personal interests have been neglected. And at some point, right about now would be nice, we do have to stop telling ourselves, you can't shift from the keep calm and carry on to the keep calm and take a break mentality, and encourage that amongst ourselves and our peers, and certainly empower or free up the juniors to do that. Those who were affected the earliest, I would say, and the most extensively, the front line of the front line, are going to be the ones who go back to life as usual last. But I think we're getting there. And again, don't want to make predictions that are going to be wrong, but that's the direction that I feel we're going into.
Thank you very much, Sophia and Chorh Chuan. We've just to let everyone know that some of the questions we've asked are combinations of some of the questions brought in from the audience. So we do appreciate everybody's contribution. We can't get to all of the questions. We're focusing on pandemic preparedness and in the future. But I want to thank Professor Tan Chorh Chuan and Professor Sophia Archuleta for joining us tonight. And your responses were exactly what we needed to hear. And we very much appreciate you getting away from your Thanksgiving feasts. And we look forward to seeing you in the near future. So thanks again.
Thank you so much.
So much indeed.
Yeah. All right. Let's move on to our next segment where I think, Dale, I think you'll join us again. And we can maybe reflect a little bit and provide a summation from 38 episodes, what we've learned and what we don't know. Why don't you lead us off?
Yeah, I'm going into withdrawal here, not being able to give my tight 15 minutes of epidemiology every time.
It was never 15 minutes, Dale.
But I tried.
Yeah.
Anyway, just to put it all together, because as you say, with 38 episodes in, and we're sitting here now, it's November 25, and there's been over 5 million immediately linked deaths, and we know there's going to be many more, especially as we identify better the all-cause mortality and also a tail from undiagnosed illnesses, undiagnosed cancers, because health systems have been absorbed by COVID. So there's a lot more to come to this story of the devastation that's been caused in what was 250 million over identified cases. And again, we know that it's the true number is a lot higher. Even still, we're getting about 450,000 cases every day, about 7,000 deaths every day, which is 50,000 deaths a week. So I don't want anyone to get the impression we think this pandemic is over. We're certainly transitioning through the phases, but Europe, especially Eastern Europe, is the current epicenter. Increasing death rates per million population. Highest country in the world now, I think, is Bulgaria, and the rest of the Balkan states and Russia. They're all suffering a lot, really, because of the their low vaccination rates and their challenging situations of bringing in or reintroducing restrictions. So certainly as Europe goes into winter, there's unfortunately a lot more misery here. We know Austria's just locked down, and other countries are looking at similar scenarios. So it's Groundhog Day in many places. The US has also got increasing concerns. They've got this very heterogeneous vaccination rate. So some places will do okay, and others I think will get really hit. So anyway, the first alert, I remember first hearing about this on December 31st. So we're looking at 23 months ago, and the first case was in Singapore a month after that, on the January 23rd, I think. And the fake was the public health emergency of international concern was announced on the January 30. But in Singapore, we're quite nicely moving into endemicity. We're seeing that discordance we wanted. We know there's a lot of cases, but not that any death is acceptable, if you like, but the ratio is really very low, and again, most of it is in the unvaccinated. So I think that message still doesn't go away. The fact that the vast majority of cases in Singapore are that are in ICU or that require oxygen, like 2/3 of those people are from the 6% of the eligible unvaccinated. So, and this is the message I'm spending a lot of time giving in WHO here, which is that there is no good vaccination rate. It's the vaccine only helps those that are vaccinated. So and even a small percentage can have a big bearing on your hospitals. But anyway, the bottom line is in Singapore, it's we're lucky. All our parameters are improving. The hospitalizations, the mortality, the severe disease, and because of that, we're seeing the restrictions ease. So I think we can be very optimistic in Singapore and other parts of the world that are doing a very controlled exit. But I think there's a lot of misery, unfortunately, in places that can't wait and exit in that smooth way. So they're my passing thoughts, David.
You made it under 15 minutes, brother.
Took 38 episodes.
Louisa.
What's my question?
Your question is, do you have a summation on therapeutics, or what's your big picture after 475 episodes?
Right. Yeah. No. So I think that it's a very exciting time for COVID-19 therapeutics. We've come a really long way since the start. And I think, I mentioned the darker days of stumbling through hydroxychloroquine, HIV antivirals. They're almost a distant memory. And I mean, talking about therapeutics now, I think most of our viewers must have heard of the two new oral, very promising antiviral agents that seem to have shown stunningly good results in the phase 3 randomized clinical trials for preventing the progression of COVID-19 to severe and critical disease in certain patients at risk. So one of them is called molnupiravir, try saying that 5 times fast, and the other one is Paxlovid, or 332 to some. And they studied different populations, vaccinated versus unvaccinated, and molnupiravir showed a 50% reduction, right, in the risk of reduced severe and critical illness or death, and Paxlovid showed a whopping 85 to 89%. So I think, does this mean that we are really finally seeing the true beginning of an end with these new agents that are coming up? And I think that, I guess since I asked the question instead of making the announcement, you can probably imagine that the rather depressing answer is that I'm not so sure yet, and I don't think that we should be so fast still to pop out the champagne. But I think that these drugs will certainly be game changers in a very big way. So they do have the potential to, be distributed much more widely and help patients to have much better access than the monoclonal antibodies, which do work very well for some groups of patients. But they are injectable agents. And so we know that some patients are limited by access, and that can be still limiting for the numbers of patients who get these treatments. But at the same time, I think there are many more unanswered questions now. And for example, is there a role of combination therapy with these antivirals? Do we have a group of patients, for example, immunocompromised patients who we know respond very differently to even vaccinations, and they are at higher risk of severe and critical illness? Is an oral tablet given for 5 days enough for them? So what about combination or extended therapy for them? And oral drugs, as convenient to take as they are, I think we still need to remember that they definitely won't be suitable for all patients still, because there are already groups of patients identified for molnupiravir and Paxlovid that are probably not suitable candidates for their use. Pregnant women and those who are planning to conceive for molnupiravir, because it works by mutating the virus's genetics, and patients on other drugs that will interact badly with Paxlovid. And it's also a drug that's expected to cause quite bad GI side effects, gastrointestinal side effects, which would be quite intolerable for some, because we know from experience that one of its components is actually a booster drug that we use for HIV treatment that causes quite bad gastrointestinal side effects. So there will still be groups of patients who won't be suitable to have any of these drugs. So I think lastly, a lot of the focus has also been on early treatment for the unvaccinated patients. But we also know, as I mentioned, there are also subgroups of vaccinated patients. And one of our audience did correctly point out that we still see higher rates or more risk of having severe and critical illness in more elderly patients who are frail with many comorbidities. And so there's still a lot to learn about how to mitigate their risk. And finally, I think what I'd like to see, or where I'm sure there will be developments as well, is that treatments that can really impact or break the cycle of forward transmission of the virus? Or is it simply something that we can take to help to decrease our symptom duration and then just help us feel better quickly, even when we get COVID? So I think that even with the leaps and bounds that has already been made, and even up against vaccine development, this is really probably one of the most exciting junctures that we have been at for COVID-19 therapeutics. And even though it's not a completely rosy picture, I'm very certain that we're moving in the right direction. So that's the hopeful end to my end of season summary and my takeaways.
Okay, great. Thank you. Thank you, Louisa. So I'm going to just try to form a summary of vaccines. And obviously there's been a lot. The first vaccine was given in a non-trial setting approximately 11 months after the first case was identified. So that's pretty awesome. And there's lots of fear associated with that. It was done too quickly, untested, et cetera, et cetera, et cetera. In fact, to me, it was a triumph of need over delay, no skipping of steps, but the usual regulatory delays that occur during normal vaccine development. So I think it's been an enormous success. We've given 7.6 billion doses of vaccine worldwide in a relatively short period of time. Unfortunately, it's been in a very not well distributed. The wealthy countries continue to get the majority, and the low and middle income countries are underserved with vaccines. So that's a big problem. That leads to the risk of additional variants evolving. That leads to discrimination. That leads to unnecessary deaths. So that's a big issue. Another issue is an absolute tragedy that occurred in the UK in August when they had to throw away 600,000 doses of AstraZeneca because it expired. They chose not to transfer it to another country in need. They just let it expire. So that's a terrible thing. There's a lot of active issues in vaccine. We don't have enough time. I don't have enough time to cover them all, but I'm going to touch on them just briefly. What do we do for people who don't respond to the 3 doses, which is going to become the norm? Instead of a 2-dose and a booster, it's really a 3-dose vaccine. What do we do for those people? Another vaccine platform, stimulating the cellular immunity. Not clear exactly what we have to offer them. Vaccination for children 5 to 12 is going to come to Singapore. I'm reasonably certain there's going to be questions about that. Its role is in preventing transmission to those who can't mount an antibody response. And to decrease the risk of multisystem inflammatory syndrome in the small number of children who get it. Who to give boosters to? There continues to be discussion locally and internationally about whether people less than 50 to 60 really benefit from boosters, but this is part of a bigger program, again, to prevent transmission to those who are at risk and don't respond. And will we need doses beyond 3? And I think that is probable. That is my assessment based on the literature. It looks like the decline in neutralizing antibody continues at the same pace, but from a higher level after the booster. But it may be a year before we need another booster or another dose. I don't know. And what's the ideal sequence of vaccines? I've spoken about that month after month after month, and it's still an unresolved problem. We know a little bit more. So let me just touch on one other issue, which is there's some concerns about the virus being transmitted to animals. Somewhere in the order of 40 to 70% of white-tailed deer in the United States, depending on where you look, have carry COVID-19, carry SARS-CoV-2. And that's a big concern, that the virus, we may be able to suppress it in the community here, but it's going to be proliferating. And again, mutants can potentially, or variants can potentially arise and be ping-ponged back into the human population, which might be an ongoing threat. So that's an unresolved issue. So that is my summation of vaccines. And with that, time is short. Let me, I believe, Dale, that this is the time that you've reminded me 15 times to hold up this book, which is the Chronicles, the COVID-19 Chronicles, Singapore's Journey from Pandemia to Peri-Pandemic Limbo. Would you like to tell us about it? And there's going to be in your chat box a URL to give you a link if you want to order it. There it is, and you can get it for a discount. Or actually, Dale's going to pay the difference.
Thanks, David. Yeah, you've heard me talk a lot about risk communications, community engagement, and the importance of it to reach out to everyone with information in as many different ways as possible. So this was a brainchild of our dean, Chong Yap Sang, and said, let's have a cartoon series, and we partnered with the Global Outbreak Alert Response Network, who have also helped with the distribution, and we've got now, I think, 150 or more comic strips that have been coming out through the course of the pandemic, describing in bite-sized information bundles what's happening. We've tried to have a little bit of humor. We've tried to give information, and it's another way of giving information. So it does chronicle Singapore's journey. It's true. The first one, if I could have my time back again, but I can't, it honestly stated that, yes, you don't need to wear a mask unless you're sick. And that was the information available at the time. About a month later, we learned about asymptomatic spread or pre-symptomatic spread, and therefore masks all the time became the order. So it tells that story as well, how we learned as we went, and how we needed to engage, and how we addressed problems with engagement as we went. So, hey, it's November 25th. So guess what? All my family's getting for Christmas.
That's very original. All right. Very good. Thanks, Dale. There's the end here is a little complicated, so stick with me. We will leave the chat box open for about 10 minutes at the end of this. We'd be very grateful for you to put in your comments. If you enjoyed the series, or if you didn't enjoy the series, we're open to all comments. Or if you just want to talk about VTL or whatever you'd like to chat about, we're happy to get your input. And then we're going to have a couple of videos. One will be a video of those behind the scene who have allowed the series and the cause of the series being a success, which we think it has been a success. And we're very, very appreciative of them, and that will roll. And then following which will be a favorite video of all the months from Dale. Did you want to say anything about that, Dale, or never mind?
Yeah, look, the videos have been fun. I think they've put a lighthearted ending to every show, and some of them have bto particularly enriching. But the one we've chosen has got a lot of feedback, and really became, in many ways, the anthem for healthcare workers to get up and dance to, and that was the Jerusalem song. So we're going to replay that. I think it'll always remind me of these years.
Good. Looking forward to it. And then we'll play out our credits with a song from my childhood. One of my hero singing cowboys, Roy Rogers. His stuffed horse Trigger does not sing, but it's a very sweet sentiment that we hope you'll appreciate. I want to take the opportunity to thank our sponsors, which are listed on the background there, which has been Yonge Llewellyn School of Medicine, the International Council from National University of Singapore, and National University Hospital System, as well as GoARN. Without them, we couldn't have done this. Let's see, with that, I think it's time for me to say, be safe, be smart. Thank you for watching, and good night.
Jerusalema ikhaya lami ilondoloze uhambe nami zungangishilana Jerusalema ikhaya lami ilondoloze uhambe nami zungangishilana dawo yami ayikholana buso wami awukholana ilondoloze zuhambe nami dawo yami ayikholana buso wami awukholana ilondoloze dawo yami ayikholana buso wami awukholana ilondoloze.
Happy trails to you until we meet again. Happy trails to you. Keep smiling until then. Who cares about the clouds if we're together? Just sing a song and bring the sunny weather. Happy trails to you till we meet again. Some trails are happy ones, others are blue. It's the way you ride that trail that counts. Here's a happy one for you. Happy trails to you until we meet again. Happy trails to you. Keep smiling until then. Who cares about the clouds if we're together? Just sing a song and bring the sunny weather. Happy trails to you till we meet